Hi, everybody. Welcome to our event on COVID-19 Behind Bars webinar. I'm Joanne Kenen. I'm the Commonwealth Fund Journalist in Residence at the Johns Hopkins Bloomberg School of Public Health, and I will be your moderator today. We will be taking questions, but put them in chat. We will have two different Q&A installment opportunities during the conversation. But we're going to hear from a lot of different kinds of speakers with different perspectives today. So let me introduce them and let's get going. We're going to start with Dr. Brendan Saloner, who's the principal investigator on this project. And with him is going to be Minna Song, who's his research associate, Brandon Doan, a graduate research assistant, Camille Kramer, senior research coordinator. And then later on, we'll have a panel with Basia Skudrzyk, who's a formerly incarcerated person and from the Prison to Pro scholar and a consultant. Michael Winans, Jr., another formerly incarcerated person and a Prison to Pro scholar. And Dr. Lara Strick, who's an infectious disease specialist at Washington State Department of Corrections. We had a preliminary conversation, and I was really struck by how much I learned from these speakers. I've read about COVID in prisons. I thought I knew about it. I thought I had paid attention. And yet they hit me with so many things, some of which were disturbing, that I hadn't thought about before. So without any further delay, I want to turn it over to Brendan.
Thank you, Joanne. I appreciate that. I'm Brendan Sloaner. I'm the principal investigator of the study. I'm going to be exceedingly brief to give time for our main presentations. So many of you know that COVID-19 has been a profound challenge in jails and prisons. And throughout the pandemic, confirmed cases have been about 5 times higher than the US average. And standardized mortality has been about 2 to 3 times higher. And these harms were in some ways entirely predictable, given the conditions of close confinement, poor ventilation, and limited access to health services present in many correctional facilities. So with the support of the Green Wall Foundation, our team embarked on this project because we wanted to add stories to the data. We especially wanted to understand how those tasked with making difficult decisions thought about the trade-offs, and to what extent ethical values were at the forefront of their thinking. We also wanted to understand how the pandemic was experienced by incarcerated people themselves, and to gain insights into the daily challenges and hardships that many endured during the pandemic. What you're about to hear is 2 research presentations focused on each of these groups. To anticipate one of the major takeaways, you will hear both incarcerated people and correctional leaders acknowledge some of the same challenges and difficult issues, but you will also hear often very opposing versions of how successfully those challenges were managed. We look forward to discussion from our panelists and reflections on where we go from here. I want to acknowledge our fantastic team with Minna Song, Camille Kramer, Brandon Doan, Gabe Eber, Len Rubenstein, Carolyn Suffren, and Chris Beyer. And I also want to thank the co-sponsors for today's event: the Bloomberg American Health Initiative, the Johns Hopkins Center for Public Health and Human Rights, the Prisons to Professionals Program, and the Berman Institute of Bioethics. And with that, I will turn it over to Minna and Brandon. Thank you so much.
Thank you for the introduction, Dr. Saloner. My name is Minna Song, and my colleague Brandon Doan and I will be presenting the preliminary results from our interviews with carceral medical and security leaders. And a special thank you to our collaborators and our funder, and views presented here are our own and do not represent our funder. So part of our study, we conducted 27 interviews from May to September 2021 with 20 medical leaders and 9 security leaders from carceral settings. And we recruited through 2 professional associations and the networks of our team members, when we used directed content analysis to code and analyze transcripts in Deduce, which is a coding software. We'll present 5 main findings here, but we found out so much rich information from these interviews, and we're in the process of writing manuscripts for peer-reviewed journals, so stay tuned. Our first finding was that while some facilities had detailed infection control plans from previous outbreaks of different infectious diseases, and this next part, I think we can all relate to. People felt unprepared for the severity and the length of the pandemic. And to adapt to a quickly changing pandemic, facilities talked to each other and consulted federal, state, and local guidelines to develop and revise their plans. This quote on the left you see here, it talks about Ebola, SARS, and MERS as dry runs of preparing for outbreaks, and said, with this one, it was like, here we go again, I guess. And they list the sources of guidance they consulted while trying to be as flexible as possible. The quote on the right highlights that correctional facilities were not meant to deal with outbreaks, and that some facilities did not have a plan in place and had to make up their COVID response on the fly.
Hi everyone, my name is Brandon and I will be presenting finding number 2. So some decision makers weighed the demands of strict COVID protocols versus staffing issues, in some cases faulting staff for the failures of infection control. And for context, through our interviews, we found that staffing issues included a broad range of issues, including staff burnout, staff shortages, as well as PPE compliance. Here we have a quote from a chief of corrections of an urban jail who described his policy in his facility to make mask wearing completely optional, except for in specific quarantine areas. In this case, he described he felt it was a personal decision, also describing how staff would have to wear the masks for 12 hours and some never got to leave their posts. So here's an example of weighing those demands of strict COVID protocols versus staff burnout, for example. Our next quote that we have presented to you is from an executive director of multiple jails. And he's describing here the second part of our finding, describing the faulting of staff for failures of infection control. In his quote, he mentions our biggest issue has been with correctional staff. He talked about how outings and parties outside of work led to outbreaks brought within the prison, and how jail administration didn't want to fight with the unions, and therefore there was no testing mandate for staff before re-entering the prison. He also recognized that across the facilities he managed, there was a 30 to 50% vaccination rate at the time. And he concludes with a pretty salient point that I think all of us can relate to, where the ways that we have publicized public health, we are now seeing it in our jails.
Our third finding is that some decision makers grappled with the hardships that COVID control measures imposed on residents, but many felt that the balance of public health need versus the burden on residents was ultimately equitable. And this person talks about the point that staff started wondering if there would be riots because of the strain of facility-wide lockdowns, quarantine, and isolation on the residents. And we see this person wondering if it's really worth it to lock people in cells for 23 hours a day, maybe an hour out, maybe not, and acknowledging the trauma that could bring, even though this was to help them and save them. And this person did acknowledge the harms of isolation and stopping visitation and services, but emphasized the purpose of these measures, that they are for the safety of the whole and not just for one, which is the justification of public health measures that infringe on personal rights. And the question that remains is, how do we do so in a way that's the least restrictive? And that is a sticky question inside the context of prisons and jails. Some people made efforts to improve the conditions of isolation and quarantine. Some of the ways they did that was by training staff, providing activities, sometimes isolating people in groups if there were mental health concerns. This quote here highlights how this person used maximum custody cells for isolation because they were structurally more likely to limit transmission than other settings that were more communal. And they even drilled holes to charge video games. They trained staff to not treat these people like they're actually in max custody. But ultimately, they ended up stopping using these cells for people that were symptomatically sick because it was still a max custody cell and not great for promoting recovery. And these two quotes show opposite ways that people handled isolating COVID-positive residents with high mental health risks. On the left, they decided to isolate the whole dorm because they didn't think that they could adequately protect against suicide in single cells, weighing the possibility that everyone in the dorm already had COVID. On the right, this person acknowledged that isolating in a single cell is a risk for people with mental health issues, but still did so in order to not expose other people.
And for finding number 5, in their appraisal of successes and failures, many respondents saw aggressive quarantine as a success story, but also had mixed feelings about the possibility of transitioning back to normal. Here on the left, we have a quote from a health and transitions manager of a rural jail who describes the aggressive quarantine process that they employed. So if a detainee was positive with COVID, not only were they kept in an isolation room, but then afterwards they were also transitioned to a quarantine pod before being released back to their general population. We also read interviews where other facilities, even when the CDC decided to or recommended the decrease of the duration of quarantine, some facilities still maintained the longer period just because that served their facility and protected their staff as much as they could. On the right, we have a quote from a regional health manager of multiple prisons who just describes a lesson learned, saying that we should probably quarantine them early from the beginning in the next round. On this next page, we have a quote speaking to the second part of our finding, the mixed feelings about transitioning back to normal, where here we have a director of nursing in multiple facilities. She described that my biggest fear is that we will go through 2022 and our new normal won't even be our new normal anymore, which she correctly anticipated. Here she recognizes that our inmates are going to be scarred. There's going to be trust issues with healthcare, trust issues with custody. And so I firmly believe we will have our work cut out for us when it comes to repairing the damage from COVID and rebuilding relationships and rebuilding trust. So this demonstrates an ongoing and also look to the future in terms of what some of the maybe unintended consequences of the pandemic will be. On this last slide, tied to each of the 5 findings that Minna and I presented, we have some policy recommendations, which I can briefly summarize for you. First, we recommend strong partnerships between medical and security, which are essential for disaster preparedness and infection control. Second, it is incredibly important to differentiate between medical quarantine and isolation versus punishment. And the most successful facilities did this via open communication, greater outdoor access and activities, as well as greater access to mental health treatment. For our third recommendation, we deeply recommend increasing staff compliance with COVID protocols, starting with accountability from leadership, which was shown to be successful in our interviews. Fourth, we want to make sure to address staff burnout and attrition by providing mental health support and other resources to staff. And fifth, given the unprecedented circumstances we're in, we have an opportunity now to reimagine a new normal for more humane conditions of incarceration, which may include extending some of the policies that were introduced during this time. For example, eliminating or reducing medical copays and communication costs. Otherwise, we saw updates to medical infrastructure, including direct phone lines from dorms to infirmaries. And so all of these will best serve us in the future if we can continue and expand upon them. Thank you for your time. And next, I will be passing over the mic to our wonderful colleague, Camille.
Thank you, Brandon and Minna. Sharing my screen. Hi, everybody. I am Camille Kramer, and oops, sorry, turned my camera on. I am Camille, and I will be talking to you about perspectives from recently released individuals. And just so you're aware, when I refer to recently released individuals, I may call them residents. So just to provide you a study overview, we interviewed 21 recently released individuals. They were in custody before the pandemic started and got out of custody during COVID. We got referrals from federal public defenders between August and October of last year. Due to our convenient sampling method, everybody in our sample was incarcerated in the Federal Bureau of Prisons. And our interviews really just captured their understanding of their experience of being incarcerated during COVID, what they thought and how they felt about it. Our sample was comprised mostly of men. The average age skewed a little bit older than the average age for a BOP resident. Length of incarceration ranged drastically from 2 years to 44 years inside, and residents were incarcerated in a geographic spread of facilities throughout the US. I'm also going to talk about 5 themes as well. The first theme being liberty restrictions. So all residents experience a COVID-19 related lockdown, some folks up to 23 to 24 hours a day. And for most of our participants, lockdown felt like punishment. And this quote on the left kind of describes that. If you're in lockdown where you don't have communication with the outside world, you can't move around the facility, you don't have recreation time or programming, it's often experienced like the SHU, or the special housing unit that is used for punishment prior to COVID. So if it looks like the SHU, it smells like the SHU, they experienced it as the SHU. Oftentimes facilities had to repurpose spaces that were not in use before COVID for quarantining and isolation. And those spaces were in very poor living conditions. In some instances, there were rodents, electrical issues, no AC or drinkable water, overflowing toilets for months at a time. And like I said, all activities and programming during COVID and lockdown ceased. And this person describes how that really was a traumatic experience. And you can see the attitudes of people change, because they went from having a very structured routine where they do their programming or group therapy sessions, can access the telephone and so on and so forth, to doing nothing all day, every day. The second theme is lack of communication and transparency. So almost all of our participants said that the hardest part of being incarcerated during COVID was not being able to communicate with their family on the outside. So communication with the outside world stopped. Residents could not access the telephone regularly. Mail was not getting picked up. They didn't have access to email or tablets. And this person, the quote on the left, describes how your familial ties start deteriorating when you can't communicate with your people on the outside. Most folks just honestly wanted to tell them that they were safe, and also to check on the safety of their loved ones in the community as well. Not only did communication within the facility, with the outside world stop, communication within the facility was scarce. And this person, and not only between the residents and the staff, but between what was going on in the facility and higher level administration as well. And this quote on the right talks about how when administrative leaders from other facilities would visit the facility, the staff would put on a mask as if it was Mardi Gras to conceal the situation. And then when they left, they would take the mask off. And the residents started observing that behavior, and they really started to reason that the reason that they couldn't or weren't allowed to speak to their loved ones on the outside or access the telephones was because they were afraid that, or the staff were afraid that it would draw negative attention to the facility. They didn't want bad media coverage. They didn't want potential lawsuits coming in. So residents started in their mind thinking that's why they're keeping us from communicating with our loved ones on the outside, just to keep the conditions that we're subjected to under wraps. The third theme is conflation of COVID protocols with punishments. A number of residents in our sample did get COVID, and some of them started describing how if you had COVID symptoms, some people were reluctant in reporting those symptoms. And that's because if you had COVID, there would be consequences. You would have all your belongings confiscated. You would be moved to a different dormitory or unit in isolation. You wouldn't get any medical attention. You would have less access to staff, residents, even the outside communication. So there was no benefit for anybody to report that they had COVID. So that really deterred folks from reporting they had any type of symptoms. And then residents started to question, well, if I don't want to wind up or disclose that I have COVID, then I'm going to refuse to get a COVID test. So the quote on the right talks about how someone refusing to get a COVID test because they didn't want the repercussions that came along with having COVID. But instead, the staff made a punishment for refusing a test. So instead of being in isolation or quarantine for 14 days for being COVID positive, they would put someone in lockdown or quarantine for 30 days for refusing a test. So they really used that punishment theme to get people to comply with COVID protocols. And the quote at the bottom really explains the mindset of a lot of our residents as far as why they're being treated the way they are. They all communicated that the treatment that they received was felt like an additional punishment to the sentence that they were already serving. And many folks just reason that to them being incarcerated individuals. And this quote goes along with that, saying that they were angry at first, but you got used to it. We got used to being mistreated. And the reaction of the staff in the facility was, if you don't want to be treated this way, then stay out of prison. The fourth theme is COVID vaccination. A number of our residents were still in custody when the vaccine came out. So they were able to speak to how the vaccine was prioritized within the facility. In every single instance, staff were prioritized first. Most residents understood why, because they did believe that staff were the biggest threat to them as far as getting COVID, because staff were the only people coming in and out of the facility. They also observed that majority of the staff refused the vaccine, so prioritizing them was not as effective as it could have been. Nobody in our sample got any type of vaccine counseling or information in regards to the vaccine. This quote describes how you can ask them questions about the vaccine, what it is, what are the side effects, and the staff would just look at you like you're crazy. Other accounts included everybody receiving a piece of paper, just asking if you want the vaccine or not, check yes or no. If you check no, there was no conversation. If you checked yes, you would get a stab in the arm and then go about your business. A number of our residents did have a chronic illness, so they wanted to ask those medical questions just to see how the vaccine would affect them, but they were not able to. Residents as well were reluctant to getting the vaccine for many different reasons, similar to reasons in the community, like the rapid production of the vaccine, potential side effects, suspected natural immunity. But I think the biggest overarching theme, which shows with the quote at the top, is that folks didn't want to get the vaccine because they didn't trust the carceral system or the government. They thought it was a scheme or manipulation tactic, and they just didn't trust where the vaccine was coming from, even if it would have been beneficial to their health. And the last theme is release, reentry, and reintegration. All of our residents in our sample talked about how they navigated release. Many folks had to submit paperwork to either get a medical furlough, get released on the CARES Act, or compassionate release. They also did comment on how staff in the facility, particularly the warden or leadership staff, would find any reason to disqualify someone for a release. And they honestly reasoned that with the more residents in the facility, the more money the facility gets. No one in our sample got any reentry planning or preparation for release, even though they were able to speak to what the facilities did before COVID. But one thing that I think is important is not only did they get any preparation, they didn't know they were getting any preparation or weren't getting any preparation. This person talks about how he was expecting to get a folder when he got out and got nothing, and he was released to nowhere. And having to navigate getting a social security card or an ID in the time of COVID, when a lot of those agencies were closed in the community, was very difficult for him. As far as reentry and reintegration, folks did adjust well back into the community. A number of our residents got stable jobs and reconnected with their families. Some people did comment on how they were still suffering from things from being incarcerated during COVID, whether it was physical symptoms like having a cough after having COVID. One person reported nightmares and PTSD. And for those folks who were released on the CARES Act, their primary worry is that they may have to return to the BOP once COVID ends or the threat of COVID ends, which they think is unfair, especially if they've successfully reintegrated. I know I've said many things in a short amount of time, so I'll just recap some primary impressions from the resident interviews. So residents felt like being incarcerated during COVID was an additional punishment to their sentence. The culture of incarceration really exacerbated their experience of being in custody during COVID. And residents believed, similar to what Minna and Brandon said, residents believed that staff could have done more to ease the burden of COVID on residents. Similar to staff communicating they weren't ready for COVID, the residents weren't prepared at all for being in lockdown for months at a time, to not being able to move around or go outside as well. And then some recommendations is enhanced bi-directional communication between residents and staff, and that includes comprehensive vaccine counseling. A few residents in our sample even disclosed to us that they offered assistance to leadership in the facility, assistance on how to improve COVID protocols to make it safe and beneficial to both the staff and the residents, but their offers weren't accepted. And then improving conditions of isolation to reduce reluctance in reporting symptoms. Obviously, not reporting symptoms could be harmful to everybody inside the facility. So making sure that residents know they won't be punished or won't have any type of repercussions for being sick, I think is going to be highly important to control COVID going forward. And that is all I have for you all. So I will stop sharing my screen and Joanne will field some questions for us. Thank you.
Okay, great. I've heard this highlights of this presentation twice, and I have found them really powerful both times. And I really hadn't appreciated the sort of mental torture of, everybody in society went through various levels of isolation, and what happened in our jails and prisons was really worth taking a minute and thinking about, even if much of it was, at least some of it was done in an attempt to protect people from a physical damage. The amount of psychological damage, I can't imagine. The lockdown, not just the lockdown, but the isolation from family, and the few things that you had normally would have had to keep you going and keep you whole. One of the questions we had, and it won't apply to the Bureau of Prisons residents, but from the conversations you had with wardens and other officials in prisons, is did you detect any differences between the private and public settings? Because since you all know better than I do the statistics of how many American prisons are now private, but it's a high number.
So I can start, and maybe my colleagues have some thoughts. To my knowledge, we did not any staff in truly private facilities. So that all facilities were under the management of either the state or a locality. But we did talk to people who were part of contracted healthcare, which is a more common arrangement. And, I think that to me was not so much the salient issue in our staff interviews. I think that actually one of the things that we heard a little bit about from some of the large correctional vendors is that they were able to take advantage of their large size to handle difficult procurement issues or to share lessons across the different facilities that they managed. I think where we really saw some big differences were certainly in between departments of corrections or state entities and jails, which are local, and often kind of jails can be small and staffing is a little bit less predictable in the jail setting. So I think really it was about the size of the facility more so than whether or not the healthcare was delivered by a contracted provider versus, like a state employee.
Did you get much sense? I mean, the virus was brought in, not intentionally, but brought in by the staff because they were out in the community. I mean, just like it was brought into nursing homes by the staff. We didn't understand that it was asymptomatic. We didn't have tests. I mean, those first months were about as disastrous a way of starting a pandemic as you could have imagined. Did you get a sense of how they had to sort of improvise, and as staff got sick or staff quit, how much of that was an issue? They really resorted to pretty drastic means, and how much of it was because they didn't have the personnel to try to do something a little softer, for the lack of a better word. Did that come up at all?
Came up a lot, and I think Camille, maybe I'll start, and I'd like to get your thoughts because you did a lot of these interviews with staff. But it seemed to me like we went into this project very interested in resource allocation. We thought that was going to be a lot of questions like who gets the ventilator. And in fact, a lot of the resource allocation questions were about how do we manage with so few staff on hand to just like take care of the basics of running correctional facilities and doing all the security work and managing kind of the surge of COVID cases. And so we heard about tough workarounds, and we heard a lot about not wanting to push the staff that were showing up to work for fear of kind of further creating problems from a management perspective. So Camille, do you have anything you want to add to that?
Yeah, I think a number of folks in our sample also talked about how staff were doing duties and responsibilities that they'd never done before, which was a change for them. But they also grappled with the staff protocols and safety guidelines as far as temperature checks or masking or social distancing when you're not at the facility. They weighed that with having very limited staff. So should they be strict on their staff and mandate testing and vaccines, or will they not have any staff at all if they do that? So I think that was trying to balance the difference between being very strict with staff as well as the staff that are still showing up and helping.
If I can add to that, so one of the things that was discussed was that the process of cohorting, of taking people out, giving them outside rec time in smaller groups to limit the amount of spread that might happen. And the decision makers wanting to make those groups as small as possible, but the lack of staff just limiting what they could do. So the trade-offs of safety and just the amount of staff time you had.
Is that why, I mean, even if you had to keep people isolated, there's a difference between 1 hour a day out and maybe 1 hour in the morning, one after out, breaks during the day. Was that basically because no one thought of that, or was that because they just didn't have the wherewithal and the staffing to do it? I mean, I'm not saying it would have been delightful to be in 22 hours or 21 hours, but I do think that the less time and the more interaction, the burden was really enormous. Was that a staffing issue, or was that no one thought about it?
I think it was at least partly a staffing issue of being able to have the staff supervise that amount of time out.
Some of the questions now are about what about the costs? Obviously there were extra costs in dealing with a pandemic. How severe was that, and how did it play out in terms of what else got worse? Because the money, I don't know how much extra money they got federally to deal with the pandemic. I don't remember how, there was a lot of money for providers and so forth, and obviously the vaccines were provided. But how did the economics make things even more difficult for residents?
Going into the study, we thought this was going to be one of the big themes that would leap out from our interviews with leaders. And we did hear about some things that could not be procured that the facilities really needed, but oftentimes that was actually because of shortages and just not having kind of enough priority placed on the Department of Corrections, rather than kind of not actually having the money to purchase like PPE and other supplies. So I think that there's going to be a cost story to unravel. The other thing to keep in mind is that during the pandemic, nationwide, the incarcerated population went down. So that kind of helped buffer some of the cost issues, although it started to rebound, unfortunately. So especially in the jails, their average daily populations were down. They had fewer people to care for, but a lot more complicated issues coming up in the context of the pandemic.
Did you get any sense of, we talked about it came out consistently in both presentations, the mental health burdens. And I don't think you need a mental ill label to have experienced. I mean, some of the conversation, some of the quotes were about inmates and residents with mental illness. But the trauma of how they lived for months, that degree of isolation, not just from one another, but the communication was hampered with quite severely limited with families, not just the in-person visits, but we've also heard about they had less electronic communication. To what extent were services offered or mental health services to alleviate this? I don't remember seeing anything on that. Obviously they were strapped, and their first priority was save lives, right? But they damaged lives in the process of saving lives. Even if the instinct was the initial instinct was protective, that was there sort of real-time recognition of, oh my God, this is really not a good thing for them, and how do we provide some kind of therapeutic or healing while they're enduring this? Was there any prison or jail that did a good job? Because this thing isn't over. Hopefully it's better, but I don't know that we're not going to have best practices for the future. Did that come up in any of the? Or was it hand
I think
wringing?
we talked to a lot of people on the staff side that talked about the burden that this had on them, on their own sense of mental well-being, that this did keep them up at night. And then, a lot of compassion perhaps for the residents, but the amount of trauma that actually came through in the resident interviews was beyond what I think we could have expected reading the leaders. I'm really interested in our second batch of panelists, who I think will speak from their own experiences on this. So
we're going to go to them in about 1 minute. And I'm just saying, what are their questions? Most of them are comments. I also, there was a mention of politicization of this pandemic, and obviously we all saw it outside. Throughout every institution in our society, there was politicization. It was probably one reason that you had a low vaccination rate among staff. I mean, I don't know that I'm inferring that from the data you presented and from what I know about the demographics of vaccination in this country. Did sort of that sense of this is a political mess, that we're caught, that things are even worse here because the government made such a mess of things, did that come across as, and we all saw it. I mean, okay, we work in public health, we're highly aware of it, but I don't, you had to be on another planet to not notice the politicization of this pandemic in the United States. So how was that perceived by people you spoke to?
I can speak to that briefly, and I think there's an added layer of just lack of information access that made everything a lot more complicated and anxiety driven within the facilities. And so there were, in terms of who you got your information from and what it was saying, it widely varied by facility. And that contributed to people's understanding and perceived understanding of basic elements like mask wearing and vaccines and the efficacy of some of these practices.
Okay. All right. We are now time to move, I believe, to our expert panel. People should still throw in their questions, and I'll work them in, or we'll come back to them. I did briefly introduce them at the beginning, but as they put their cameras on, I'll reintroduce them and let them fiddle with their buttons. Basia Skudrzyk, Michael Winans, who are both formerly incarcerated persons who have pretty striking stories, and Dr. Lara Strick, who I think it'll be interesting to hear from her, partly because she was working in a quote blue state, and they had their struggles. They had a very aggressive public health stance in the state of Washington, but I mean, there's no state that did well in this period in our country. Let me start with Basia and Michael, and let's do it alphabetically. Just sort of tell us each where you were how you even became aware that there was a pandemic, and what did it begin to mean for you? And then we'll get into some of the CARES Act issues in a couple of minutes, because that's highly pertinent. But just bring us to the scene. Basia, where were you, and how did this new reality, frightening new reality, wherever you were, how was it presented to you, and when did you start understanding how it was going to change your day-to-day existence?
Sure. So we were glued to the TV screens, so we were very much aware of what was going on the outside, probably even more than family and friends were aware of what was going on the news, because you have so much protected time on the inside that any information that you can read or see about is what you value the most. So we would see just an uptick in information, and I would say it started in January. What happened in China, just kind of trying to map all the outbreaks of COVID that were, going on internationally. And then, we would start to see maps, the red zones of who else has COVID. Oh, it's in Chicago, it's in Washington, it's in New York. So that fear and that stress started to build as everyone was watching internally and externally. I think for those 3 months, that January to March frame, we still were not aware of how profound those effects would be, or how they would transfer into a closed system, let alone the outside system. But we were just extremely worried. You're in a space, in a building with limited communication. You're receiving information as everyone else is receiving through task force, through emails, through hearsay. People, make up stories even sometimes because they don't know how to connect the dots of what truly is going on. So there was just panic, I would say. And then we would kind of adjust on a day-to-day basis based on the information that we received from the administration on the inside.
What state were you in?
I was in Illinois.
Okay. Michael, Where were you? You were in a different physical kind of structure. Explain a little bit more about your experience through as this mysterious
Well, like
virus
Basia,
began.
I was located in New Jersey, and like Basia, we had heard the reports on the news in January and February, but things didn't really become real until early March when someone fainted in the visiting room and there was a panic. And that's when visits were canceled. And it looked like the staff said, we have to take this thing seriously. I think at the facility where I was located, we really suffered from a leadership vacuum. And I understand COVID was difficult for everyone across the world. And I don't want to just dump on the correctional facilities, but our warden never stepped foot back on campus once it was announced COVID as a global pandemic. And so what he did was he deputized subordinates to carry out the fight against COVID, but they were not up to the challenge. And I think that the power dynamic between staff and inmates, because there were already contentious relationships, it just exacerbated once it was time to really lock down and go into COVID fighting mode. And so I was at a camp facility where doors are typically unlocked. You have access to the outdoors and access to staff whenever you need them. And immediately we were locked into dorms. And when that happened, I think it had a psychological impact on a lot of people. There were folks who were coughing, and the ailments were there. And folks were just getting sick and trying to alert the staff, but staff had a massive shortage. And so I even had a buddy, unfortunately, who he had complained for over a week. And by the time they got to him, his symptoms were so severe that he passed away in the hospital. And so that showed me that when you have a lack of good leadership during a crisis, it can have such detrimental impact. And in this case, a life was lost. So it was tough all the way around, but that's how we were introduced to it when a visitor actually fainted on the visiting room floor.
And did the visitor actually have COVID? Was anyone ever sure?
Well, it was
There was
assumed.
no tests for, we didn't have our little take-home test. We didn't have anything, available in most places in early 2020.
It was just assumed because, we had never seen anything like that before. We had never seen anyone pass out on the visiting room floor. And so after that point, it was chaos. We did receive masks and the staff were given PPE, but you had a lot of staff members who just refused to wear masks. They refused to wear PPE. And so it was just very contentious, and there was a lack of harmony and symmetry between staff and inmates, and it only worsened over time.
Dr. Strick, you were working in Washington State, correct? What was your job before winter 2020? And how, as you saw what was coming, I don't think anybody saw totally what was coming, but as you saw that this was not something happening in China that was going to stay in China, as you realized it was going to become part of your life and your work, tell us a little bit about that process. Were you able to, no one really understood the science, we didn't know what we needed, but were you able to even access what you thought you needed at the time, and were you able to communicate it? I was working in a newsroom. I had trouble communicating to my colleagues how bad it was going to be, and as bad as I thought it was going to be, it was worse. But just sort of that dynamic of, let's get ready. Something bad is happening, even if we don't understand it, and how are we going to take care of our staff and the residents?
Yeah, it's a great question. So before COVID, I was an infectious disease consultant where I was seeing patients in clinic with an assortment of different infectious diseases. And at the time COVID was starting, I called the administration, or it's possible they called me, and I told them they should go ahead and hire somebody quickly to handle COVID. Because I could not I already was covering my job. I was covering the job. I oversaw a kind of release program, and recently had lost my social worker, so was covering their job, and basically said that this would be like taking on a third job.
So they gave you a mirror and said, here's your new assistant?
No, to give them some credit, they very quickly went ahead and they hired a public health / infectious disease person from the community. And that person lasted 1 week. And it was very clear to me that handling COVID in a correctional facility really was not something that somebody from the community can step in and even attempt to do. And so whether I wanted to or not, I transitioned kind of taking on a leadership role with COVID and wound up instead hiring on people to help me with the clinical side of my work, which was much more feasible and similar to what somebody from the community could accomplish.
Did you personally have enough PPE at the beginning?
I think we, like everyone else, struggled with PPE, and I think similar to many other facilities,
excuse me, sorry.
the folks went to work for better or for worse, and started making our own PPE. So with the help of residents in the facilities, with our staff, we made our own gowns, our own masks, and our own eye protection.
And what about the how long until you were able to get masks for both the staff and the residents? Those who, I don't know if it was mandated. I mean, they couldn't have mandated until you had them, but I don't know how much it was mandated. But as we began to understand what masks did, and at that point in 2020, cloth masks were more effective than they would be against later variants. What we were able to provide for people, other than, I don't know how much isolation was in the prison you were working in, but what tools did you have other than just emotional isolation?
Yeah, no, it's a great question. And I think obviously, like most things COVID, it kind of morphed as time went on. Initially, we were able to get kind of made cloth masks mandatory for staff and voluntary for the population. It then kind of changed over to, once there was an adequate supply, to surgical masks that were mandated across both populations. And then more recently instituted an additional kind of voluntary N95 program, again, for routine use, not necessarily in situations where an N95 would be required as part of PPE. I think, you know, for those folks in the audience that are not used to kind of working inside a correctional facility, just the idea of custody allowing folks in population to wear a mask that obscured their face and identity, when like we struggled with things as, you know, simple as makeup and other things in the past, was a huge culture shift within facilities. And the fact that to this day, right, the majority of folks continue to wear masks within the facilities.
And in the facility you were working in, were the isolation protocols as draconian as some that we just heard about because they had nothing else to do? I don't mean to say, like, how could you do this? I mean, you would do, if you did it, I mean, it was like you had very limited choices given this. It was a disease that we had no vaccines, we had no medication, and it was killing people. I mean, I understand there was a lot of desperation of how, and no one knew how long it was going to. You could think, okay, we could do this isolation because it's going to be 2 weeks, not 3 years.
Yeah, I think similar to the community when all of this started, right? I don't know that any of us knew what we were getting into. And kind of, as you're saying, I don't know that any of us at the beginning predicted that this was going to go on for this long. I think many facilities, and I'm talking kind of just across the board, not necessarily for Washington DOC specifically, but I think most correctional facilities did what they thought was right at the time. And completely agree that many of those measures, both whether in corrections, potentially more so, but in the community as well, right? A lot of people wound up being isolated. School children wound up not going to school. And I think we learned a lot around the impacts of public health measures across the board. I don't know what the right response could have, should have been. I think many facilities made attempts to release individuals at the beginning of this in many states, but given the number of people that are incarcerated, I don't know that any state was going to get to a place where COVID would not be more significant than it is in the community.
Michael, do you want to talk about the CARES Act? Explain it for anyone, briefly, for anyone who can't. There were a lot of acronyms and who can't remember which one is which, and the impact it had on you. And also, I remember hearing you talk about some of the internal politics around, who gets out and why. It didn't seem to be very science-based.
Yes, I believe in April of 2020, the CARES Act was signed into law. And so it gave facilities the authority to send home inmates who met a certain criteria. Some of that criteria dealt with the amount of time that they had already spent in prison, their progress report, if they were apt to contract the illness. And so it was left up to the case manager to initiate the process. And the case manager really had the most authority over the entire process. Everything else was a rubber stamp. The warden would sign off as long as the case manager said yes. The problem was the case manager had certain people that they were favorable toward and others that they weren't. And so what we started to see was a lot of favoritism when it came to people being sent home. I mean, there were people who were maybe a year or two away from their release date who had to remain even though they were, perfect for the criteria, they fit. And there were people who had 7, 8, and even 9 years left who were being sent home. Now, praise God, thank God for anyone who was able to go home early, but you could see that there was favoritism being played. And so the good thing is over time, we were able to get a new warden who ended up, bringing some type of balance and some type of parity to the situation. So the CARES Act I'm home on the CARES Act. I don't know if Basia is as well. Okay. And so we're allowed to serve the remainder of our time on home confinement. We're able to reintegrate back into society, to work. Obviously, we have different curfews and things that we have to make sure we adhere to. But, there have been people who have been sent back, some who did not have the support of family they thought that they had prior to being released. Thankfully for myself, I had a lot of support to be able to get back up on my feet and functional again, but that is not everyone's story, as some of your staff has told us earlier today. And so it gives people an opportunity to show themselves approved that they can make it out here in society and that they are not their worst mistake. And I believe that in the end, we'll see that sending people home early and allowing them to get back on their feet is much more beneficial than not.
And more beneficial isolated in a place where they were still at risk of infection. And do you worry about is your situation that you can fulfill your sentence at home, whatever time you have left? You're not among the people who are worried about having to get sent back when the health emergency ends?
Well, there has been great concern from people because there isn't anything official stating that we will not be sent back. All we really have is promises from the administration that's currently in office saying that if you do what you're supposed to do, you will not be sent back. There have been rumors about commuting sentences for people who are still out on home confinement. So we're just kind of like in a waiting period, but I just have faith that we'll be able to stay out, and I don't have too much more time left on my sentence anyway.
And Basia, if I'm remembering correctly, you finished you're done.
I'm done.
You were released, you were sent home, and you were able to successfully complete your sentence at home. And I also, correct. If I'm remembering correctly, you just got into a great graduate school program.
I did.
Right, but you also, can you talk a little bit about, so you're not dealing with the anxiety of, am I going to have to go back? You have been able to sort of, move on in a way that we can all admire. But talk about, you're a mom, right?
Yes.
Talk about the, and I don't mean to not ask Michael about his family too, but we have a limited time to ask. I can't ask everybody everything, and I don't want to imply that only moms matter, but I'm asking her this question. How much contact did you have with your family and your kids pre pandemic shutdown, lockdown, and post? I mean, how much, not that it's ever good for them to the
It's
limitations,
not.
but
Yeah.
how did it get worse?
Yeah, I mean, I think I shared with you on our first call, we had 300 minutes allocated per month to call our family, our friends, and every minute we had to pay 35 cents. So again, like Mike's shared, I was incredibly blessed to have a support network where friends and family were able to put money on my account to have that privilege to call back home. Same thing with email, same thing with video conferencing. I do have to say the administration, when they really did realize the severity of COVID and the mental fatigue and anxiety that people were feeling, especially, not being able to move, being on lockdown, in a dorm of 120 women, they realized that they needed to inject some more type of communication protocols. So they opened up the video conferencing for free to every single person in our dorm, and they increased our minutes to 500. However, that was such a great gift, but then everybody was on the phone and on the video. So, the volume increased in time, but so did the activity. So the touch points were basically maybe even less. You really had to like stand in line for 45 minutes to an hour sometimes to get that 15-minute phone call back to your loved ones. But there was just a lot of handwriting every day. I wrote letters to my girls every single day. I emailed, I called. I tried to reassure them as much as I could to my family and to the girls. But when there's so many unknowns, people are scared, especially when you can't see them in that waiting room that was completely removed for health precautions, obviously, but it was difficult. Just like anyone is experiencing right now with COVID, not being able to see your family or travel outside, it's hard.
Okay. Dr. Strick, how much isolation and solitary kind of housing was there in the facility you were working in, and what, if anything, were you able to do to mitigate the sort of emotional toll, the mental toll of that?
Yeah, I think all facilities struggled with us, and truthfully to this day, I'm not sure what the right balance is, right? I think it's a really tough question. Thankfully, COVID has become less fatal, although time will tell what long COVID really comes down to. I think we changed a little bit over time. I think at the beginning, like everyone else, right, we were much stricter with isolation. And as noted, we did everything we could to kind of get our custody colleagues to understand that regardless of where somebody was physically placed, even if they were placed in what people often call the SHU or IMU, otherwise maximum custody, that it wasn't a punishment. And so making that very clear, we tried to allow people to continue to have access to the video games, access to phones, access to outside time, snacks. They are mental health, and truthfully, many of our community custody colleagues, as people's kind of sentences were commuted, they were less busy for a while, and they packaged up activity packages and other art supplies for folks in prison to keep folks busy. More recently, we kind of are entering the next phase of COVID, as I think everyone is coming to the realization that this is not going away, on letting individuals to kind of decide whether they want to quarantine as a unit or whether they want to be removed from that unit and take the extra protection of being kind of quarantined in a single cell environment, trying to even when folks are in isolation, I think as more and more data came out to say that spread outside occurs less commonly, to group folks together outside in order to minimize some of that isolation. But you know, it's been a long 2.5 years and kind of trying to figure out what the best way to do this is. And I don't know that anyone really knows.
I have been working in the questions that our viewers have been asking. I'm going to wrap up. Just each of you in like a couple of just lightning speed. Michael, what do you wish the world knew about COVID behind bars?
I just wish that the public had a bit more sympathy and did not view everyone through the same lens. There are a lot of great people who have spent time behind bars, and they've spent more time than they probably should in order to be healthy, coming out and being a productive citizen. But just to have compassion and mercy and to recognize that, you know, we can improve in that environment. Criminal justice is an issue that's a hot button topic right now. And I think one of the things we need to look at is giving people another opportunity, because not everyone is a hardened criminal. And there are people who have a lot to bring to society.
Basia?
I think what Mike said was absolutely perfect. And I think it's just being mindful and open and not judgmental of people's circumstances. At the end of the day, we're all human beings. We all have family. And we all want to live a better life. And when you're placed in conditions that are very scary, it's hard, and it really does challenge you. And you have to have a very strong mindset, but not everyone is capable of doing that. So providing people with better solutions to overcome difficulties in life, I think, are really important.
And before I turn to Dr. Strick let her close, you know, I moderate a lot and I meet a lot of people. I mean, these nowadays on a computer screen. The two of you really made an impression on me. I really learned a lot from you, and I admire your willingness to sort of be the face of this. And hopefully, as doctors like Dr. Strick deal with whatever the next phase and the phase after that, you know, hopefully what you've experienced will make her job of communicating it easier. Dr. Strick, I'm going to give you the final. What do you want the world to understand about what you've been through, and what the people your patients, which is the entire prison population in a pandemic, what does the world need to know about them?
Hard to follow Mike and Basia. I really appreciate you guys sharing your personal stories. I think, you know, from my perspective, it is the number of people we incarcerate and the resources we put towards those systems do not match. And I think the pandemic really highlighted that. And I think I could not agree more with Mike's sentiment. People, you probably said it better than I'm going to say it, but people are not their worst act and deserve a second chance. And as I think was mentioned in the first half of this presentation, is that correctional facilities really were not built to handle it, well, to be therapeutic environments, let alone to respond to a pandemic.
Okay, well, thank you all for your willingness to talk about your experiences. Dr. Strick, your ability to provide the services you provided when it wasn't what you initially chose. Just a big thank you to all of you. I learned a lot from you, and I hope that your stories travel and have some impact. So thank you very much.
Thank you.